Dr. Igor Elyash is a general surgeon with Valley Medical Group. He attended New York College of Osteopathic Medicine for surgery. He completed his residency in surgery from Lutheran Medical Center and a fellowship in bariatric surgery and minimally invasive surgery from Princeton Healthcare. Dr. Elyash is board certified in surgery and has an office in Ridgewood. Thank you so much, Dr. Elyash, for joining us this evening.
Thank you so much. It's great to be here tonight. Had a great time giving a talk on hernias last year, and very glad that I was invited back for another talk. So tonight we'll be talking about gallbladder disease, which is a very common problem and something that we see very often. As a general surgeon, it's a very significant portion of my practice. So the goals of today's talk, we're going to discuss gallbladder disease, and our real specific focus is going to be on gallstone-related disease involving the gallbladder. The gallbladder is an organ that has many different rare disease processes and various conditions that can affect it, but some of them are very rare and some of them are not very common. And for that reason, I wanted to focus today on things that are so prevalent in the community that it would behoove us to know a little bit more about it. So we're going to talk about the disease process. We're going to talk about treatment options that are available, and we're also going to focus on the actual operation involved and the recovery that's involved with the operation. And of course, I'll be happy to answer any questions that you'll have at the end of the presentation. So what is the gallbladder? Before we start talking about gallbladder disease. So the gallbladder is this bag-like organ that lives underneath the liver. And it's connected to the liver, it's connected to the pancreas, it's connected to the small intestine through a series of ducts and channels. And the main function of the gallbladder in our body is that it stores the digestive juice, known as bile, that is created and formed by the liver. And it stores it in its bag and allows for a very quick release of it so that we can digest fatty foods and foods that have a rich fat content much quicker. And the other function of it is that it concentrates this digestive juice and allows it to be in its typical form that's released. So this is kind of a rough schematic of what the anatomy looks like. So we see that the gallbladder is this bag-like organ sitting underneath the liver. It's roughly in the middle of the liver. And through this series of ducts and channels, so there's this common hepatic duct, common bile duct, it is connected to the pancreas, which sits behind the stomach. And eventually, all these connections are attached to the small intestine, or specifically the duodenum, which is the first part of the small intestine. And so every time we eat a meal that is rich in fats, our body sends these hormonal signals that stimulate the gallbladder to release the bile, that goes down and mixes with the excretions of the pancreas, which are also it's also very much part of our digestive process. And all these contents go into the small intestine, where food is digested, broken down, and eventually absorbed by the small intestines. And this bile is eventually absorbed by the small intestine, and it cycles back to the gallbladder, where it ends up being stored. And so this process is a very efficient process, and it's how our body functions, and it's how our body normally functions. So let's now talk about some of the abnormalities. So gallstones are very common. About 10% of the population of the United States has gallstones, and the majority of the time, people don't even know they have gallstones because most people don't have symptoms. And many times, gallstones are found on routine studies for other conditions, and it's a very common consultation that I get. So what increases our chance of getting gallstones? Well, the incidence is increased with age. We know that it's also much more common in women, theoretically, because of all the hormonal changes that are involved in the female menstrual cycle. And so for this reason, it's also much more prevalent in pregnancy because of all the specific hormonal changes that are involved with pregnancy. We know that it tends to run in families. There's oftentimes when I see a patient in the office, I'll ask them if they have a sibling or a parent that has ever had gallstones or gallbladder disease, and oftentimes it'll be positive for that. Patients who have been on chronic nutrition, who have been in the ICU for a very serious medical condition, chronic artificial nutrition tends to bypass the intestines, and so the bile is not utilized, and so it's concentrated very, very thoroughly, and it ultimately leads to the formation of these stones. As we'll see, there's also stones that can be formed from the pigment that is released from blood cells that are broken down. So certain blood disorders and blood diseases are prone to the formation of stones. We know that in our United States, with the growing population of morbid obesity, the incidence of gallstones has also increased. Previous bowel surgery also sometimes predisposes us to gallstones because of the removal of the bowel and basically abnormal absorption of the bile. Cystic fibrosis is a condition where the motility of our cells is limited, and so it also allows for the concentration of bile. There's certain medications that can predispose you to gallstones, and also rapid weight loss. So perfect example of this is for weight loss surgery a long time ago, when weight loss surgery was first becoming popular. Surgeons used to routinely remove the gallbladder because the thought process was, you're going to get stones, you're going to get problems, and we have to remove the gallbladder. Nowadays, we don't do that. We really only take out the gallbladder when there's symptomatic disease. So there are really two types of stones that we classically see. The most common stone that we see in the United States is definitely the cholesterol stone. So the bile, it's made up of various ingredients, various components. It's made of salts. It's made of this pigment that's called bilirubin. And it's also made from cholesterol. And if you've ever baked a cake before, if you've ever made have ever dabbled in cooking, you know that if one ingredient is overabundant, the recipe completely changes. And so this is exactly what happens with gallstones. So you have these concentrated stones and sometimes something called sludge, which is formed, and eventually this can cause problems. You can also get these pigmented stones. So pigmented stones are much more common in countries outside of the United States, in non-Western countries, where there's a lot of blood-borne disorders. For example, sickle cell anemia, other hemolytic anemias can cause it as well. And what ends up happening is that the breakdown of red blood cells leads to this buildup of this pigment called bilirubin, which is concentrated again in the gallbladder and ultimately ends up forming stones. You can also have these stones form in a situation where the liver is functioning poorly, such as liver cirrhosis, or again, when someone is on artificial nutrition. You can also get infected stones, which can sometimes be called brown stones, which are also need to be treated and also need to be treated with antibiotics. And we'll discuss some of these treatments in a little bit. So how do patients with gallstones present? Well, as I said, the majority of the time, about 10% of the population has stones, but only a very small fraction actually has problems related to these stones. So majority of people will not have any problems, and they'll just routinely find this on imaging studies for other conditions. But sometimes these stones can start causing problems. Typically, what ends up happening is these stones will cause a blockage at the neck of the gallbladder, where the gallbladder connects with some of these ducts and channels, and they can cause temporary or sometimes permanent blockages that will lead to spasms of the gallbladder, which will lead to symptoms of pain and discomfort, and will ultimately present themselves. But also sometimes these stones may not cause blockages. Sometimes they may be small enough where they leave the gallbladder and they start going downstream. And when they do, they can sometimes cause blockages in the ducts outside of the gallbladder, which can, because of its connection with the gallbladder, with the liver and the pancreas, it can cause strain on the liver. They can trap bacteria and lead to infections, very serious infections sometimes. And they can also cause an inflammation of the pancreas. in the United States, the two most common causes of inflammation of the pancreas are alcohol and gallstones. And so gallstones are a very significant contributor to pancreatitis. In many cases, these stones can pass on their own, but sometimes these stones will need to be removed with endoscopy. And I'll show you some images a little bit later. And very rarely, something that we usually don't see too often, but sometimes these stones can cause such a large erosion and inflammatory process very close to the gallbladder and the intestines, and they can sometimes form this abnormal communication with the intestines and pass into the intestines and cause blockages in the intestines. This is something called the gallstone ileus. This is something that's very rare and usually only happens to patients who are very sick, who've had long-standing disease, and typically are treated surgically because you have to remove that stone to address that blockage. But the classic presentation of gallstones and gallbladder disease is classically described as pain in the right side of the abdomen, because that's where the gallbladder is. Sometimes this pain will radiate to your back. Sometimes it'll radiate to your shoulder because of the inflammation in that surrounding area and because of the inflammation to the diaphragm. Usually this type of pain is associated with nausea and vomiting. And very classically, it's triggered by rich, fatty foods. It'll typically happen shortly after a meal, usually 1 or 2 hours afterwards. And symptoms can last for a short period of time sometimes, or they can be so severe that they can last for a long time. And most oftentimes, when patients have these kind of symptoms, they will end up going to the emergency room. So how do we evaluate the gallbladder? Well, there's definitely blood work. We can look at signs of inflammation in the blood. We can look at signs of strain on the liver, strain on the pancreas in the blood work. And then there's also a series of imaging modalities that we can utilize to better study the gallbladder. So one of the first tests that we use, and one of the safest tests, is the ultrasound. It's a test that we use on pregnant patients. It uses sonographic energy, doesn't really use any radiation, and it allows us to visualize a lot of important structures. And so on this picture, we can see the outline of a bag, and inside we have these little fuzzy shadows, and these are gallstones. So sometimes, in addition to that, you can also see some fluid that is outside of the gallbladder, which is a sign of inflammation. Sometimes you can see a thickening of the wall of the gallbladder. And sometimes you can also see a dilation of some of those ducts outside of the gallbladder, which can show that maybe a stone has passed through, or maybe a stone is still stuck inside. So it's an amazing first study that we utilize. Sometimes when patients come to the emergency room, they may have vague pains or vague symptoms, and they'll get a CAT scan. And you can also see gallstones on a CAT scan. It's a very good study for it. The ultrasound is a better study to look for inflammation, but you can definitely see it. And I can show you with these images. So you can see the liver over here and over here. And right below the liver on this section, you have the gallbladder. And you have some stones, these little white stones, because they on X-rays and on CAT scans, they light up very well. And this is a great picture if you're looking kind of at a standing patient. So this is the liver, this is the gallbladder, and these are some stones. Now, another study that we utilize in a situation where we're not 100% sure if it's the gallbladder that's causing the major issues or the symptoms. So the ultrasound is a great study to look at the structure and the anatomy of the gallbladder and the stones. The CAT scan also, it's a great test to look at the structure. But what if I want to look at how the gallbladder is functioning? If it's functioning well, if it's functioning normally? Well, one of these studies is called the HIDA scan. And the HIDA scan is a nuclear medicine scan that utilizes a kind of this radioactive marker that is preferentially taken up by the liver. And we know that the liver takes up this marker, then slowly secretes it into the gallbladder, then eventually secretes it into the intestine, kind of the same way as our bile is secreted. And so we can see in these images, if the gallbladder lights up and lights up very quickly, we know the gallbladder is taking up. There's no blockages in the gallbladder. It's functioning normally. We know that the gallbladder is functioning well. So the HIDA scan can show us if the gallbladder doesn't light up in these images, we know that the gallbladder is obstructed, that there's really no flow of this compound, which means that there might be some inflammation there. Also, if the gallbladder is taking things up very slowly, it's a sign of something called biliary dyskinesia, which means that the gallbladder is not functioning well, that there's probably been some chronic inflammation that has limited the function of the gallbladder. So this is a great study for looking at the function of the gallbladder. So now that we kind of have identified symptoms, we've identified the overall presentation and how we identify what's going on. Now let's look at some of the treatment options. So we mentioned that with people who don't have any symptoms, generally for most people, there's really no need for any treatment. But for people who have symptoms, there are some options that have been utilized, and I'll kind of talk to you about the non-surgical options first. So the first option is in a situation where fatty foods and foods with a high fat content trigger your episodes. One of the recommendations is to avoid those foods. This may be very difficult because following a very strict low-fat diet can be very difficult, and sometimes it's not the patient. Sometimes you go to someone's house or you go to a restaurant and they'll swear to you that whatever they're giving you is completely fat-free, and you'll end up having something that has quite a bit of fat and end up having symptoms of pain. So this is something that has a very high failure rate. And usually this is a pretty temporary solution because most of the studies have shown that once your gallbladder really starts causing symptoms, you have a high chance of having additional episodes, and most likely you're going to continue having these episodes. In the past, there's also been some medications that have been utilized. So ursodeoxycholic ursodeoxycholic acid is a medication that breaks down and dissolves some of these stones. And it's been utilized for weight loss surgery patients where they want to try to shrink the stones. And again, it's a temporary solution because unfortunately about 50% of the stones will recur in 5 years. And ultimately the stones keep coming back and ultimately the symptoms keep recurring. So it's a temporary solution. Some other options that have been utilized aside from surgery. So laser lithotripsy is pretty much what we do for kidneys. So it's where we use extracorporeal energy to break down the stones. So in the kidneys, this is important because the kidneys are very important organs that you need to preserve at all costs. And so removing a kidney for a kidney stone is not a very good option, not a very safe option. For a gallbladder, this has sometimes been utilized for patients and as a temporary solution for patients who may not be able to tolerate surgery. But again, once the gallbladder forms stones, it's going to keep forming stones. Another option is for certain patients who are very sick to tolerate surgery, patients who are in the ICU, for example, patients who have significant medical conditions that prevent them from tolerating surgery. Another option is potentially putting a drain into the gallbladder to decompress the gallbladder and relieve some of the inflammation. This is utilized for patients who may not be good surgical candidates, and it's still utilized for that. But as a solution for patients who are healthy and who can tolerate surgery, again, this is a temporary solution. And lastly, this is, I know, a very big word, but we mentioned that when the stones leave the gallbladder, when they get stuck outside of the gallbladder, you have to somehow get them out. You can get them out surgically, which has been used traditionally, but sometimes you want to do something that is a little bit more minimally invasive, and sometimes you want to do something that uses endoscopy, or what the gastroenterologists utilize. And so endoscopic retrograde cholangiopancreatography, or ERCP, is an option. And I'll show you this picture. So whenever you have a stone that's outside of the gallbladder, so in one of these ducts, what ERCP does is you put an endoscope, or the same scope that you do for colonoscopies and upper endoscopies, goes inside the mouth, goes down the esophagus, goes into the stomach, ends up going into the small intestine. And then they make a little opening in the connection where the ducts of the gallbladder connect to the intestines. And they go in, they sweep the stones and remove the stones with a balloon or a basket. And then they can also see if there's any additional stones that are stuck. You can also do biopsies if there's any narrowing or strictures, if you're concerned for any malignancy or any masses. And this is a great solution for patients who have stones outside of the gallbladder that are stuck inside. So I'm a general surgeon, so the big portion of our talk is going to be the surgical option here. And so, which patients are really the surgical candidates? So we talked about that medical treatment oftentimes fails because of because of the fact that the stones will keep coming back. So patients who really have any sort of symptoms are really good candidates for removal of their gallbladder because ultimately the gallbladder will keep producing the stones. Patients who have acute cholecystitis, which is that situation where the stone is stuck inside at the neck of the gallbladder and there's persistent ongoing inflammation and sometimes an infection, this oftentimes requires an urgent operation because the symptoms are very severe and very debilitating. We mentioned patients who have certain blood disorders, who have these pigment stones that keep building up. So some of these patients, for example, patients who are young and who have sickle cell anemia, hemolytic anemia, may benefit from a removal of their gallbladder. Sometimes the gallbladder, aside from gallstones, can also develop polyps, kind of like the polyps that you get in your colon. For small polyps, it's usually nothing to be concerned about. It's just something that we monitor regularly. But for any polyp that's larger than a centimeter, because of the slightly increased risk of cancer, it's a good idea to remove the gallbladder. And then there's something called the porcelain gallbladder. So when you do some of your images for pain or for other findings, if you see that the gallbladder is significantly calcified, which means that there's been a lot of inflammation in the area, while it's not a definitive sign of malignancy or cancer, there is a slightly increased risk for it. So in those patients, our typical recommendation is to remove the gallbladder. So how do we remove the gallbladder? Well, we always start with the history and the tradition of how we used to do things. And really pretty much up until the late 80s, early 90s, the way that we removed the gallbladder was through open traditional surgery. And what this really involved is making an incision underneath the rib cage. So this is the rib cage. It's making an incision underneath the rib cage right around the location of the gallbladder, going through the entire abdominal wall, going into the abdomen, and removing the gallbladder. Now, because this was done through a big incision, this was definitely associated with a significant amount of pain. This is associated with a higher risk for an infection because of the larger incision. And oftentimes these patients, when they would have this surgery, they'd spend several days in the hospital. They'd have a significantly prolonged recovery. And this was not an ideal surgery for patients who were older with more medical problems or more medical complications. And so it was the solution then, but it really wasn't ideal. So then in the mid 1980s, surgeons were experimenting with these small instruments that were placed through these ports into the abdomen. And then they were using fiber optic cameras that were using light that allowed us to put a camera inside the abdomen to take a look at the organs inside the abdomen and to perform these very complicated surgeries using these very small incisions. So the small incisions would mean a much faster recovery, a much faster return to your everyday function. And while in the beginning there were certainly some problems, like with any new surgery that's being done, certainly by the middle of the 1990s, by early 2000s, this procedure, which used to involve several days in the hospital and significant pain, was an outpatient surgery with a recovery that was much faster. And these are the port placements that we utilize. So we in my practice, I place a 5 millimeter port, so about 5 millimeters right above the belly button. I place two 5 millimeter ports right on the side. And then the largest incision, because that's ultimately where the gallbladder is going to come out, is about 11 to 12 millimeters. So a very, very small incision. And through this incision, we stretch the skin, we stretch the muscle, and we remove the gallbladder through this incision. Sometimes if the gallbladder is a little larger, sometimes we do have to make a little bit of a larger incision, but still significantly smaller than the traditional open surgery. And the other benefit that we really see, so when you could do this with the open surgery, but during the surgery, and every surgeon has their own preference of when they do this. Some will do this routinely for every operation. Some will do this selectively. I tend to do this selectively. You can put a catheter through one of the ducts outside of the gallbladder. You can put some contrast material inside, and you can take a series of x-rays which allows you to definitively define the anatomy so that you don't cause any injury. But also the other, and the more important thing is it allows you to check for any stones that may be stuck outside of the gallbladder. I do this selectively because I tend to do the ultrasounds, sometimes an MRI, to identify the anatomy before the operation. So I only do this in a situation where where I'm not sure about the anatomy, and I want to be 100% sure that what I'm removing, what I'm cutting, is safe and not dangerous to the patient. So this is a picture of this. So you can see the catheter over here going into the duct from the gallbladder, the cystic duct, and then you can really make out these are the other ducts. These are the two hepatic ducts that will go to the liver. They form this common hepatic duct, which then combines with the duct from the gallbladder, and then they form this common channel that will eventually meet its way into the small intestine. And this is a normal study. You can see that there's no obstructions. There's nothing that's stuck. And the reason why it's narrowed down here right before the intestines is because there's this little ampulla, or this kind of this little sphincter that prevents things from backing up into the ducts from the intestines and potentially causing serious infections. So in addition to the laparoscopic surgery, which is the minimally invasive approach, there's also robotic surgery. And I like to think of robotic surgery as kind of an extension of the laparoscopic approach. The robotic surgery is not AI driven, where the robot makes its own decisions. The operation is still carried out by the surgeon, but instead of standing over the patient scrubbed in with the instruments in my hands, what I do is I sit at this little console right next to the bed, and I control with my hands and my feet the instruments that are inside the patient. And these instruments are a little bit more complex than the traditional laparoscopic instruments. They move around with better articulation, which means that they move around kind of like your own hands inside the patient. And with robotic surgery, you're also using a three-dimensional camera. So you're using generally a better camera. And these are some of the instruments that we utilize, and you can see they tend to bend and articulate, so they tend to have a lot more of a range of a much more complex range of motion. The ports are roughly placed very similarly. The ports are slightly bigger with the robotic ports. They're 8 millimeters as opposed to the 5 millimeters. And then, of course, there is certainly one port that has to be larger than the others because that's where the gallbladder is removed. And the other benefit of the robot is that you can utilize something called firefly technology. So this is kind of a pretty interesting thing. So you use a dye very similar to what we talked about with that HIDA-scan that lights up and is very visible. And it's preferentially taken up by the liver and the gallbladder and the ducts. And then you can use this kind of black light technology almost that allows you to really see where the gallbladder connects to the liver, where it connects to everything else, so that once again, to identify the proper anatomy and to minimize any injury. So whenever I do a robotic operation, I always use this technology so that I can feel comfortable that what I'm removing, what I'm taking out is absolutely safe. In my practice, I generally tend to use the robot in situations where I feel like the patient is going to have a much more complicated operation, and also depending on patient preference as well. But if you compare the robotic approach to the laparoscopic approach, it's just a different set of tools, but they're identical as far as their outcomes. So for most people who get their gallbladder removed, as I mentioned, with the laparoscopic or robotic approach, it's generally a same-day surgery. It's done completely under general anesthesia, so people are completely are asleep for the entire operation. You don't feel a thing. And during the operation, we inflate the abdomen with CO2 in order to see everything. So in the first couple of days, most patients will tell us that their main complaint is pain from the CO2 gas. We try to release all that gas at the end of the surgery, but because everything is still stretched out, you might feel pain in the abdomen, you might feel pain in the back and the shoulders. And of course, there's the effects from the anesthesia. You might feel a little nauseous. You might feel a little groggy. I've had some patients mention that they may have some short-term memory issues that typically will resolve. And of course, there's the effects from the tube that is in the throat during the operation. There are certainly IVs that are placed in. So your body is definitely a little sore after surgery. After a couple of days, most of that discomfort really starts moving away from the entire abdomen and really starts kind of becoming localized at where the incision sites are, and specifically at the biggest incision where the gallbladder is removed. I tell my patients they can move, they can climb the stairs, they can walk around. In fact, moving around and walking may help with the gas pain. And that if they're feeling pain, if they're feeling discomfort, they can rest. They can start off, they can try using over-the-counter medication, but if the pain is really severe, we do prescribe some strong pain medication. Most patients really after a few days can start to transition away from that. And usually what I find is that most people by 2 weeks after surgery are feeling, maybe still a little sore, but more or less back to their usual self. And as people recover and as their pain is improved, they can do more and more. They can do most cardio-based activities around the house. My only restrictions after surgery are for a month, I put everyone on a low-fat diet so that the body can get used to not having a gallbladder. And also, I also restrict lifting, anything more than 20 pounds. Sometimes some surgeons will go for lower weights. And this is just to prevent hernias after surgery, to allow the body to heal after surgery. So probably the number one question that I get asked about gallbladder surgery is, you're removing a major organ from my body. Can I live a normal life without the gallbladder? And this is a very important question. I describe the gallbladder to my patients as a nice to have organ. So it's nice to have, it makes your life a lot easier, but it's not necessary. You can live a normal life without it in most cases. I like to think of the gallbladder as if you have a big closet in the front of your house that allows you to get easy access to your coats and all your clothing, and it just makes your life a lot easier. But if, let's say, you didn't have that closet, you can still get by. You can still find ways to bypass it. And that's what our body does. So the liver still continues making the bile that it was making beforehand. And so instead of being stored in the gallbladder, the body just releases it as needed with meals. In the beginning, your body's going to have a hard time adjusting to it. Some patients will have diarrhea after surgery. Some patients will have indigestion after surgery. And for every patient, the amount of time this is going to happen is very different. I've had some patients who have absolutely no issues with fatty foods after surgery, who can pretty much have a steak dinner the day that they come home from surgery, which is very rare. Most patients are generally in the category where at first they might have some difficulty with foods that have a high fat content, such as red meat, such as dairy products, such as fried food and greasy foods. And they may have more diarrhea, they may have more discomfort, more nausea. But most people within a month start seeing some improvements. And if it's not better within a month, after a few months, most people are able to get back to a pretty normal diet. There's a very small percentage of people who may have lifelong issues with fatty foods, but the majority of people will be able to get back to a pretty normal diet and also a pretty normal life after gallbladder surgery. Now, we talked about surgery as being the solution for symptomatic disease and for quality of life, but surgery is not without its risks. And specifically, when I talk about any surgery, I always mention that there's always the possibility of pain after surgery. There's the possibility of us as surgeons causing bleeding, infections, and also potentially injuries during the surgery as well. With any laparoscopic surgery, any minimally invasive surgery, I always mention to my patients that yes, majority of the cases I am able to do laparoscopically, but in a situation where there's an emergency, in a situation where there's any potential severe risk to my patients, and I feel from my judgment that the safest approach would be to make a larger open incision, in those cases I do that. It's not a very typical thing. In most cases, we're able to stay laparoscopic, but it certainly does happen. Anytime you create wounds in the body, there's going to be risks of complications to the wounds where wounds will not heal properly. They're going to lead to some big scar formation. You may develop open wounds or a breakdown of wounds. Sometimes those stones that we have in the gallbladder may move downstream as we're taking the gallbladder out, and they could get stuck outside of the gallbladder, and you can get what's called a retained stone. Usually, these will pass on their own, but sometimes they will require the gastroenterologist to do that ERCP to get it out. Sometimes we may cause an injury that may hurt some of the ducts that connect to the pancreas, to the small intestines. And sometimes these are mild, and sometimes they can just be easily watched and managed, maybe just repaired with a few sutures. But sometimes these require some additional complicated procedures, and sometimes they require another surgeon, a liver specialist, to be involved to really change the course of the anatomy and really can make things more complicated. This is usually very rare. It doesn't happen too often, but it is a possibility. And it's more common in people who have very severely inflamed disease where it's sometimes difficult to make out the anatomy. And this is why in those cases, we really have a whole series of tests that we utilize to really make sure that we're removing the proper structures. There's also risks from the anesthesia, and of course, there are certainly other risks as well. So, in conclusion, gallstones are a very common disease formed process that affects the gallbladder, and it's one of the most common disease processes that we see in the United States. Luckily, while gallstones are very prevalent, only a small fraction of our patients will have symptoms related to those stones. Symptomatic disease is usually an indication for surgery because, as I mentioned, the gallbladder will continue making the stones and will continue making symptoms once it does. The modern approach of taking out the gallbladder is usually a minimally invasive approach, and for that reason, it's usually a much faster recovery, a much faster return to your everyday life, and generally much better suited for our patients. And most importantly, if you have any concerns, any particular question about whether or not you have symptoms, it's always wise to seek the consultation of a general surgeon. If you're not sure, if you're not 100% sure if your gallstones are causing problems, speaking with a general surgeon, most of the time we can get to the bottom of it and we can answer any questions that you have.
Thank you, Dr. Elyash. That was excellent. There are a few questions that came in, and so I'm going to go right ahead and right into the questions. First one is a two-parter. The first part, is there something that can be done at the time of a flare-up to relieve the pain?
So that's a great question. I get this quite often. Oftentimes when patients will have a really severe flare-up, they will throw everything at it. They'll drink alkaline water, they will drink lemon water, they will drink all sorts of antacids. So the problem with that is that when you have an active flare-up, it's related to a stone that is temporarily or sometimes permanently stuck in the neck of the gallbladder. Usually how it happens is when you have a meal that has some rich fat content, the gallbladder will start squeezing to try to get the bile out. And just as it squeezes, that's what causes the pain. Luckily, as time goes by, as the food leaves that part of the small intestine and goes downstream, the hormonal the hormonal input to the gallbladder should stop, and usually the symptoms will go away on its own. There's really unfortunately, no real medicine that definitively stops these flare-ups. It's just pain medication, and if symptoms do not improve, and if you're not feeling better, it's better to seek the emergency room or an urgent care, especially if your symptoms are just associated with nausea, really severe pain, and they're debilitating. Most episodes will typically get better within 30 minutes to an hour, but if it's not getting better, it's better to be evaluated.
Great. And then the second part of the question, is it common to have a flare-up infrequently? So for example, 3 times in 3 years, but each flare-up is, more uncomfortable and it results in emergency visit to rule out anything else.
Yeah, so this happens very, very often. With gallbladder disease, it doesn't really follow a definitive pattern sometimes. I have some patients who have these kind of symptoms where they have symptoms maybe once in a while. They're not very frequent, but when they happen, and patients know they have them. What happens is when the gallbladder squeezes, these stones sometimes get lodged in, and they'll cause these obstructions. But sometimes, as the gallbladder squeezes, the stones are just move around, and they don't cause any blockages. So it's really the blockages that will cause these symptoms to occur. And so sometimes I've had patients who've come to me and said, I had a steak dinner yesterday and I had no symptoms, but then today I had something fried and my symptoms started today. There's no rhyme or reason, but the presentation doesn't follow a pattern, and it's also the same thing where I have a patient who may have one episode and never have another episode again, but statistically, most people will have additional episodes in the future.
Great. Okay. So this person is wondering how a surgeon is trained, specifically with like the laparoscopic surgeries and the robotic surgeries. How is that done? Are they trained on real patients? How does that work?
So that's a very big part of medical education, and specifically surgical training has really changed from when I was a resident. It used to be, my mentors kind of grew up in a time where a senior surgeon would basically get called and they'll say, okay, start the operation, do the operation, and the senior resident or chief resident would take a junior resident through an operation, and that's how you would learn. That's definitely changed, and when I was a resident, that was certainly not the case, because every operation that I did as a resident, there was always a senior surgeon or an attending surgeon in the room. So when you're a resident, there's certain operations that are much more complicated. There's certain operations that are easier. And so as you kind of progress in your training, you're allowed to do more and more of supervised operations. For gallbladders, generally, it's not a case for surgical interns. It's usually for sort of second, third, usually third, fourth year residents. And throughout your residency, you do a significant amount of gallbladders, because it's a very common problem in the United States, and it's something that we see very often. And pretty much almost every time that I was on call as a resident, there was always an appendix or a gallbladder that caused a flare-up. So as you progress in your training, your attendings allow you to do more and more things. And usually by the time you get to your fourth year of residency, your fifth year of residency, you've seen and done so many of these that you're really doing these supervised, but you're doing these really on your own and independently. And so by the time most residents graduate, they've done probably several hundred of these. And then in addition, as you get into practice, So when I started into practice, any complicated surgery, anytime that I was particularly not comfortable doing something, I would always have a senior partner always involved in my care, because the most important lesson that we get taught as surgeons is be safe. Don't do something foolish. Don't be a hero. If you are not comfortable doing something, always have backup. Always have a backup plan. It's one of the reasons why all our board exams, you get asked all these questions, because you always have to have a backup plan, because that's that's how surgery works.
Great, thank you for that clarification. Another question. You had mentioned that gallstones are very common in the US. Are gallstones more or less common worldwide compared to the prevalence in the US?
Yeah, so gallstones in general are common worldwide. By most of the statistics and what we call the epidemiology for patients in Western countries and in countries where we generally have access to the Burger Kings and the McDonald's and all the fast processed foods, we generally have a higher rate. And it's generally much more common. So we see this in the United States, in Europe, and in most of North America. When we're talking about, and these are specifically stones that are made of cholesterol. For other parts of the world, so sub-Saharan Africa, in other countries where they may not have as much processed foods, or the typical stone is a pigment stone, and that's usually due to certain blood disorders, because in certain countries, in certain rural areas, they may not have access to, not rural and really poorly populated areas, they may not have access to medical care. They may not have access to treatment of a lot of these blood disorders that we can easily treat in the United States. And so in those countries, it's certainly much more common to have those pigment stones. But gallstones are prevalent throughout the world.
Okay. And I see one more question here. So if anyone has any further questions, please feel free to type them into the Q&A button there. So the last question I have right now, can sludge in the gallbladder without stones be a cause for removal?
Absolutely, yes. So I like to think of sludge as gravel, kind of cement, or kind of like wet sand. When it's in the gallbladder, it's concentrated. It may not have the formation of a stone, but it's basically tiny little pebbles of stones, kind of like wet sand. So because they're not as large, they can actually also cause obstructions. They can also cause, the stones can move downstream. And so gallbladder sludge can also be responsible for symptoms. Another thing that we really didn't mention, but in certain medical conditions, so some of our ICU patients who are very, very sick, who are on medication that is helping get where, for example, where their blood pressure is low, or their oxygenation is not great, and they're in the ICU, they're on a ventilator, they can sometimes get something called acalculous cholecystitis, where the gallbladder may not have a single stone, but because of the deprived oxygen, deprived blood supply, they can get an inflammation of the gallbladder without a stone. And that's something that we see in the ICU. That's something that we see with patients on supportive nutrition, for example. So whenever you have symptoms of right upper quadrant pain, and it's radiating to the back, and it's associated with nausea, and has all the classic signs of gallbladder disease, but all you see is sludge, or sometimes no stones, it may be the source of your pain, maybe the source of your symptoms. So certainly sludge is very much responsible for gallbladder disease.
Great. It's just a couple more questions. My almost 19-year-old son has multiple gallstones as seen on a sonogram. He never had an attack. He's never had an attack or pain. Should he consider removal?
So it really depends on a number of factors. It depends on if he has any other medical conditions, if he has any blood disorders. But generally, most people who have an incidental finding of gallstones, as long as their blood work is okay, as long as there's no signs of any disease process involving the pancreas, As long as there are no signs of obstructions or any other symptoms, generally speaking, this is something that we tend to watch.
Okay. And I think this is kind of two-part question is came in separately. So I apologize to the person who asked the question if I'm saying this incorrectly. But is there a way to cleanse the sludge? And they've heard that eating beets can help. Is this true?
So there are a number. I've oftentimes patients will come to me and they've read something on Instagram or on the internet where there's lemon water, bicarbonate water, beet juice. You know, unfortunately, there's just not enough studies that support any of these remedies. For some patients, they may help with symptoms, but there's really just no medical evidence supporting that. Is that one thing that we know for sure is that even if you clear the gallbladder of stones, for example, using some of those medications that we talked about, the gallbladder, once it starts concentrating these stones and making these stones, it's just going to continue making these stones. So it may be a temporary solution, but ultimately you may have additional symptoms in the future.
Okay. And then I see one more question, and it goes back to the training. Um, so this person understands the residency and the mentor program, but like with robotic training, now with the increasing usage of computer use and, how is that done when someone is sitting at a Da Vinci module? How are you trained with that in specific?
Yeah, so and that's a great question. So the Da Vinci robot and the intuitive company in general has seen a significant increase in the use of robotic surgery with general surgeons. When I was a resident, there's maybe a small percentage of people who were using the robot who I'm sorry. There's certainly a significant number of naysayers who were saying that the robot was not well tested, it was not well utilized. But the Intuitive company has done really a great job in training surgeons. So if you're a surgeon who's interested in becoming a robotic surgeon, first thing they do is they have you go to a series of viewings where you see other surgeons in other hospitals utilizing the robot, doing the operations that are consistent with your practice. Then what they typically do is they send you for a course in Atlanta where it's a 2-day course, sometimes a lot longer, where you really get to practice and you get to utilize the robot and you become more comfortable using the robot. And then you do some of these surgeries on cadavers and sometimes on pigs, and you become more fluid and more comfortable. So then, before you can even start doing the operation on real humans on live patients, you then have to go through hospital modules. Every hospital has their own particular set of rules. Valley is very particular. Before I started at Valley, I had been doing the robot for quite some time, and I had several hundred cases under my belt. But before I started at Valley, they wanted to make sure that they have the simulator on the robot. They wanted to make sure that I passed every single station and passed it in the 95, 9, or well over 90 range, so that they know that I was comfortable in using the robot. And so this tested various skills: sewing, cutting, using cautery, things like that. And then after using the simulator, after getting all this testing, then you are mentored by a senior surgeon who is a robotic surgeon. And there's a certain number of operations that you have to do before you are allowed to operate on your own. And even then, there's only a set number of operations, and it has to be in the setting of your practice. So as a general surgeon, I had done many laparoscopic cases before I started doing the robot. And so when I started doing the robotic gallbladders, I knew the steps of the operation. It's just you utilizing the robotic technology. Same thing with a hernia repair. And for you to move on to more complicated procedures, again, you have to have that mentorship, you have to have that guidance. There's been a lot of scrutiny, but ultimately, before they allow surgeons to do these complex operations, you really go through a series of tests before you are allowed to do anything on your own. So hopefully this answers your question.
I think that was very thorough. Thank you so much. I think that's it for the questions. Very informative presentation. Thank you so much, Dr. Elyash, for taking time out this evening for presenting on this topic. And we hope to see you again for other topics. I'll probably be reaching out to you again sometime in the future.
Absolutely. Thank you so much.
Okay, so at this time, I'd like to remind everyone at home to take a few minutes to fill out the survey using that link that will be emailed to you. Actually, it'll be emailed to you tomorrow morning. So if you are interested in future Valley Live events, please visit www.valleyhealth.com/events for any upcoming programs. And I did chat that into the chat, so you can always grab that URL from there. And with that, I'd like to say thank you so much again, and thank you for joining us this evening, and have a wonderful evening. Thank you, Dr. Elyash. Have a wonderful night.
You too. Thank you.